Hey everyone, and welcome to this EMTprep series of videos covering static cardiology scenarios. The goal here is to clear up some misnomers about this station during your ALS NREMT practical skill eval, and we want you to feel confident knowing what's expected of you so that you can walk in and knock this thing out on test day. We're going to present 4 scenarios in each of these videos, just like you'll see during the test, followed by some time for you to prepare a treatment and also give your evaluation of what the ECG strip is showing. So let's get started. So scenario number 1. You respond to a nursing home for a 90-year-old woman complaining of generalized weakness. Nursing staff directs you to the patient who is sitting in a wheelchair. She tells you she has been feeling weak for several days. Her vital signs are as follows: blood pressure 126/86. Her pulse is as shown in the ECG strip above. Respiratory rate is 18 and unlabored. She's satting at 99% on 2 liters via nasal cannula. Your monitor shows the above rhythm. So take some time to write out how you would handle the patient in the ECG strip given in the previous slide. The rhythm is atrial fibrillation, and we know that because it is an irregularly irregular rhythm, and we cannot distinguish the P waves in the R to R intervals. For the treatment, we're going to start with body substance isolation, seen as safe. Once you get confirmation that you're seen as safe from your proctor, we're going to provide oxygen. We'll continue giving 2 liters via patient's nasal cannula. We'll set the monitor on. We'll start an IV at 20 gauge. Patient has relatively stable vital signs and is alert. So she could be weak from a persistent AFib or another cause, and so we want to verbalize that to the test proctor. Ask the patient about chest pain. We'll ensure a 12 lead is taken to rule out an MI. We'll transport code 1 unless vital signs become unstable or the patient's mental status deteriorates. Just in case, we're going to have Cardizem at 0.25 milligrams per kilogram ready to draw up if the patient becomes symptomatic. We're going to monitor her vital signs every 5 minutes, and this patient is considered stable, although being elderly, she has the potential to become symptomatic, especially since her weakness started several days ago. Scenario number 2. You arrive on scene at the supermarket parking lot for an unconscious homeless man. Bystanders found him sprawled out next to a trash can and called 911. He is unresponsive when you attempt to wake him, and you cannot palpate a carotid pulse. Your monitor shows the above rhythm. Take some time to write out how you would handle the patient in ECG strip given in the previous slide. The rhythm is ventricular fibrillation. We know this because it's an unorganized ventricular rhythm that does not result in cardiac output. For our treatment, we're going to say BSI is the scene safe, and once we get confirmation that the scene is safe, we'll continue. We'll immediately begin high-quality CPR, rotating compressors every 2 minutes. We'll set our monitor to defibrillate and deliver defibrillation dose. We'll consider calling for more resources as needed. We'll have an ALS partner establish an IV and push 1 milligram of 1 to 10,000 epinephrine. We'll have another ALS partner establish an advanced airway, such as an ET tube or a King airway. While airway is being established, another partner will be managing the airway with a BVM attached to high-flow oxygen. We'll perform rhythm checks every 2 minutes. If they're still in ventricular fibrillation, we'll defibrillate. After the second rhythm check, we'll IV push 300 milligrams of amiodarone for the antiarrhythmic effects. We'll alternate epinephrine and an antiarrhythmic dose at each rhythm check. For example, 3rd rhythm check, give epinephrine, 4th rhythm check, give antiarrhythmic, etc. Once a second dose of amiodarone is given, 150 milligrams IV push, we'd consider lidocaine or consider continuing with epinephrine only. We'll consider our H's and T's, our treatable causes. We'll monitor for ROSC, and if ROSC is achieved, we'll transport code 3 to the nearest trauma hospital, and we'll monitor vital signs every 3 to 5 minutes. If ROSC is not achieved, we'll continue working the code in the field until all protocols are met to cease efforts. Scenario number 3. You are called to the residence of a 55-year-old male. His wife ushers you into the living room where the patient is lying unresponsive on the couch. You cannot palpate a carotid pulse, and the above rhythm is present on the monitor. Take some time to write out how you would handle the patient and ECG script given in the previous slide. The rhythm is pulseless electrical activity, which is any rhythm that does not have a pulse associated with it. For our treatment, we're going to do BSI, scene safe, and once we get confirmation that our scene is safe, we'll continue. We'll immediately begin high-quality CPR, rotating compressors every 2 minutes. We will also consider calling for more resources. I'll have an ALS partner establish an IV and push 1 mg of 1 to 10,000 epinephrine. I'll have another ALS partner establish an advanced airway, such as an ET tube or a King airway. And while that airway is being established, another partner will be managing the airway with a BVM attached to high-flow oxygen. We'll do a rhythm check every 2 minutes, and if the patient stays in PEA, we'll push epinephrine every 3 to 5 minutes. We'll consider our H's and T's, which are our treatable causes, and we'll monitor for ROSC. If ROSC is achieved, we'll transport code 3 to the nearest trauma hospital and monitor vital signs every 3 to 5 minutes. If ROSC is not achieved, we'll continue working the code in the field until all protocols are met to cease efforts. Scenario number 4. You respond to a college dormitory for a sick person. A 22-year-old male is sitting in the lobby and waves you over. He states he had a rough weekend, has been vomiting for 2 days, and now feels weak. His vitals are as follows: blood pressure 106/70, respiratory rate 20, pulse as shown, satting at 100% on room air. Your monitor shows the above rhythm. Take some time to write out how you would handle the patient and ECG strip given in the previous slide. The rhythm is first-degree heart block. We know this because the PR interval is longer than 0.2 seconds or 5 small boxes. Our treatment, we're going to do BSI, scene safe. Once we get confirmation the scene is safe, we will provide oxygen at 4 liters per minute by nasal cannula, attach our monitor, and start an IV. The patient has relatively stable vital signs and is alert. It is likely that this patient needs fluids because of his vomiting history. I'll transport code 1 unless vital signs become unstable or the patient's mental status deteriorates. I'll hang 500 milliliters of normal saline and allow it to flow wide open. I'll monitor vital signs every 5 to 10 minutes because this patient is stable. I'll also consider 8 milligrams of Zofran via IV push if the patient remains nauseous. So that's what you can expect on test day. You're going to get 4 scenarios, 4 rhythm strips. You're going to have to identify what the rhythm strip is and provide a reasonable case for how you're going to treat this patient.